Okay, welcome back to second week of seminar that we've been running this term. Joining us today is Dr. Kirsten Bott from Radiology in the McKeag Institute. Dr. Bott completed all three of her degrees, so her undergraduate, master's, and her PhD at Brock University in Ontario. And she is currently a postdoctoral fellow here at the University of Calgary, working in opportunistic CT analysis for osteoporosis screening and then how it can be incorporated into Alberta Health Services. Some of her current interests are related to medical imaging and bone, which I'm sure we'll hear about. And she's currently working towards a career as an implementation specialist to take science from bench to bedside. So thanks, Kirsten.
Thank you. Great. So the title of my talk today is Two Birds, One Scan. So looking at opportunistic osteoporosis screening using clinical computed tomography scans. I wanted to start with the why for this research. So the overarching goal is to develop an osteoporosis screening tool that repurposes clinical CT scans for earlier identification of individuals at risk of developing osteoporosis. So as we know, osteoporosis is a disease characterized by low bone mass and deterioration in bone tissue, which can lead to an increased risk of suffering a fragility fracture. So it's often called the silent thief, since you have bone loss without any symptoms, and many individuals actually don't know they have osteoporosis until they've suffered a fragility fracture. In Canada, there's an estimated 10% of all adults over the age of 40 and 21% of postmenopausal women that are osteoporotic. And given that individuals inevitably lose bone as they age, and we have an aging population, which has been coined the silver tsunami, identifying key strategies to mitigate these age-related conditions like osteoporosis are really essential. What we're trying to avoid is fragility fractures. So a fragility fracture is defined as a fracture that occurs from a standing height or less, and most osteoporotic fractures occur typically at the spine, wrist, or hip. For today, I'm going to be focusing mainly on the spine and then throwing a little bit on the hip. And the reason why we care about osteoporotic fractures is that there's a high morbidity and mortality rate. So for example, in Canada, if you suffered a hip fracture, in the first year post that hip fracture, you're at a 25% risk of mortality. The way that we actually diagnose osteoporosis is using dual energy X-ray absorptiometry, otherwise known as a DEXA scan. So with the DEXA scan, it utilizes two different X-ray energies to differentiate between bone and soft tissue, which provides us with aerial bone mineral density. And I'd just like to note, since it is an aerial measure, it technically is not considered density. Then in terms of how we actually diagnose it, so if you are over the age of 50, we would use a T-score. So that is the standard deviation from a reference population for comparison. So in this case for osteoporosis, it's 20 to 29-year-olds. And then if you're below the age of 50, it would be a Z-score that we would use, which is the standard deviation from a sex and ethnicity and age-matched reference population. And then in terms of actual diagnosis for osteoporosis, according to the World Health Organizations, you're considered to have a normal BMD if you're within one standard deviation of the mean. And then you're considered to have a low BMD if you're one standard deviation below the mean, and osteoporotic if you are greater than 2.5 standard deviations below the mean, either for the T-score or Z-score. So although we have these effective treatment strategies, a key component of treatment is the identification of these individuals that are at risk of osteoporosis. So despite well-established clinical practice guidelines for screening, which include doing BMD or DEXA scans, BMD testing or DEXA scans for all women and men over the age of 65 years, and individuals over the age of 40 that have already suffered a fragility fracture, there remains a large gap between the best practice and the care that's provided, leading to an overall underdiagnosis. So just to note with DEXA, there are still some limitations, even though it's still the gold standard for diagnosing osteoporosis. So first off, with the DEXA scan, like I already mentioned, is a two-dimensional scan giving us aerial bone mineral density. And the problem with this aerial bone mineral density is that it actually causes an overestimation of the BMD. So larger bones typically yield a larger BMD value. And then secondly, positioning is really important, again, because it's a 2D measure. How you position the person when you do the DEXA scan can really change how that BMD score comes out. And then secondly, as I've already alluded to, there's an osteoporosis treatment gap. So again, what's considered best practice is not actually maybe what's going on. So leading to, again, overall lower screening rates. And so Some of these limitations can be overcome by using computed tomography or CT scans. And I'd also just like to note that DEXA screenings are less commonly conducted compared to the number of CT scans that are being performed for other various clinical diagnoses. So with CT scans, there's millions of CT scans that are performed yearly, and they're performed often at the relevant osteoporotic sites that we see those fractures, so at the hip and spine. And they're performed for various reasons. So it could be for something like kidney stones, oncologic screenings, or abdominal pain. And an estimated 43% of patients over the age of 60 that have undergone a CT scan were found to have either osteoporosis or already have suffered a fragility fracture of the spine. So this gave a little more background on CT and how it kind of works. So as I've already kind of mentioned, CT is going to actually give you a 3D view. So it's a volumetric bone mineral density. And how the CT scan actually works is you'd have your X-ray source and then your X-ray detectors on the other side. Sorry. And then as the person is fed into the gantry, the X-ray source and detector are going to be spinning around. So you get these images from various different angles. And so it's like a helical scan as they're fed through. And then someone who's way smarter than me was able to create these algorithms and then transform these images into a 3D rendering. And then often what you'll hear associated with computed tomography are Hounsfield units. So all Hounsfield is actually standardizing the CT numbers. So it is a measure of attenuation, how many X-rays actually got to the detector. And so the technical definition is it's a linear transformation, taking the measured attenuation coefficients, and then it's actually being calibrated to air and pure water. So since Hounsfield units are a measure of density in some ways, they can sometimes be used as a surrogate measure of BMD. But, oops. And then also with CT, if we want to get to that BMD, we would have to actually convert those Hounsfield units to BMD. So just to take a note on the Hounsfield units, since they are somewhat of a measure, a surrogate can be used for BMD. So the nice thing about using Hounsfield units, if you were to consider them as a surrogate for BMD and then extrapolate that to osteoporosis screening, is that you can use it direct from the scan. So no BMD calibration is performed. I'm going to talk about calibration momentarily. And then there are some studies that have actually suggested that there are some thresholds that you can apply for the Hounsfield units as an indication of whether a person has osteoporosis or not. So although there's some pros using Hounsfield units for osteoporosis diagnosis, there's also some major cons. So main one being, although pros are that it's additional, there's no additional scanning required and no calibration, as I've already mentioned, and it can be performed retrospectively. However, the cons is that tissue composition can significantly affect those Hounsfield units. And then the more major one is actually the energy that's used for the CT scan. So if we just look over to the right here, we can see there's a study where they actually took the same individuals and they scanned them at various energies. So if you compare the tube voltage of 80 kV to the tube voltage of 140, you can see you have this stepwise decrease in the Hounsfield units of the trabecular bone in the L1 vertebra. So if we were to actually be using this as an osteoporosis screening tool, we wouldn't really know which is correct. And that's where calibration becomes really important. So for CT calibration, again, you're converting those Hounsfield units to a BMD measure. And if we're thinking about this in terms of a clinical setting, BMD actually means something to clinicians, whereas Hounsfield units probably doesn't. So in the research setting, we include a calibration phantom in the scan field of view. And what a calibration phantom is a phantom that contains rods of varying node densities and is placed under the patient and scanned simultaneously. So when it's scanned simultaneously with the patient, this is known as synchronous calibration. So this method minimizes the differences in BMD values across different CT scanners, models, and as well as scan protocols. However, in the clinical setting, these phantoms are typically not used and they're not included in the scan field of view. So I've already mentioned synchronous calibration, and then the other one where we're still using a phantom is asynchronous. So in this situation, the phantom is still scanned, but is scanned separately from the patient. So the phantom may be scanned at either weekly or monthly intervals, but again, this workflow with scanning the phantom is typically not implemented in the clinical setting, even though it's being scanned separate from the patient. I'm just going to touch on how the calibration actually works. So since we have those rods of varying node densities, we can then plot the Hounsfield units. And then since we know what the BMD of those rods should be, we're able to create this calibration curve. And then we can plot our area of interest. So let's say it's the trabecular bone of the L1 vertebra against this curve to find where the BMD should be. And then for these rods, they are either usually composed of hydroxyapatite or dipotassium phosphate. In terms of asynchronous CT calibration, although it's the closest gold standard to that synchronous calibration where the phantom is included with the patient, the pros is that the phantom can be scanned separately from the patient, and you get the similar calibration curve as the synchronous calibration, and it reduces the potential for image artifacts since the phantom is not included with the patient. However, there are some cons. The main one being that you need to actually scan the phantom, and that's not done in the clinical setting. And then another disadvantage is that this technique, it introduces some scanner instability. So if there's scanner instability between when the patient was scanned and when the phantom was scanned, you're not able to correct for this. So as I've already mentioned, these calibration phantoms, either synchronous or asynchronous, are not typically used in the clinical setting. So that kind of falls away. And that's where internal calibration comes in. So with internal calibration, this uses no phantom whatsoever. So instead it uses internal reference tissues. So if you look at the colors here, we have yellow for air, red for adipose, blue for skeletal muscle, green, kind of see it's for blood, and then the magenta color is representing bone. So those are the typical tissues that you would use if you're doing internal calibration. And a key advantage is that the scanner instability effects are smaller since the regions of interest, so these little colors that I've shown here, are selected closest to the bone of interest instead of from the phantom, which would be positioned below the subject. So it's one of the advantages, and it is truly opportunistic. So with the internal CT calibration, there's actually a couple different ways to do it. Jumping ahead. So it's replaced by the scan regions. And so commonly used ones, like I mentioned, air, adipose, skeletal muscle, blood, or cortical bone. And then the different approaches, the first one is that you can create a reference data set approach. And then the second, which is the one that Dr. Boyd developed, is actually it estimates the effective energy, and therefore you can then extrapolate what the tissue BMD should be as well. So a little more doesn't matter. Option one. So for the reference data set, there's two options. The first option is taking the reference material densities, and it's determined by taking the average of a calibrated reference data set. So it's the calculation of equivalent BMD values for selected internal materials, so like the ones I mentioned, from a reference data set using asynchronous calibration. So you still need to scan a phantom at some point and create this data set. And then for the second option, it's using a multilinear regression between BMD values obtained from an internal and from asynchronous calibration. So again, it involves a calibration phantom at some point to create these data sets. So both require reference data sets specific to a scanner as well as scan protocol. So it requires a large amount of data, which is a disadvantage. And we need to know the information about the scanner and scan protocol if we're then going to use it later for an individual that's gone in for another reason if we want to use these techniques. So there are some commercially available screening tools I did just want to touch on very briefly. Getting some funny looks here. So the first one is Virtuost. And so with this commercially available tool, it is using CT images. However, it's a bit of a black box. We don't actually really know how they're doing it. They haven't released details about that. So we believe, though, that they are creating a calibration to create these calibration equations based on reference data sets for each scanner and each scan protocol. So this is quite time consuming, and the equations will require continual upkeeps to maintain accuracy with new scanners and/or protocols that are being combined. And that is out of the US and it is FDA approved. And then the second one is 16-bit row, which was developed at Sunnybrook in Toronto. So this one can only use 2D X-rays. And it's not intended as a diagnostic tool for osteoporosis. So what it actually does is it outputs this row score. And so for these row scores, they have been correlated with DEXA-derived BMD scores at both the hip, the femoral neck, and as well as the lumbar vertebra. So with the row scores, it can then trigger a DEXA scan, but again, it is not providing a BMD measure. So that's where kind of our technique comes in. So this is, again, the Dr. Boyd's technique that he's developed. So the benefit of this method of internal calibration is that there's no reference data set required to derive a calibration equation. So more specifically is based on the mass attenuation coefficients from the National Institute of Standards and Technology. So they've gone through for each of the reference tissues and seen how those tissues interact at various different energies. And then it's being put through to see what iteratively put through to estimate the effective energy. So it's iteratively correlating the internal reference ROIs, Hounsfield units, and the corresponding mass attenuation coefficients at each energy level. And that's trying to maximize the R square value here. And so that's how we're getting the effective energies and then actually able to do the calibration. Also, when this study was developed, they actually scanned full body cadavers in the spine region with a density phantom included in the scan and compared it to both asynchronous and the internal density calibration. So we're getting all three types of calibration here. And as you can see, there's a really high R square value for the asynchronous BMD calibration, as you'd expect, but also for the internal calibration method, we also get a really high R score. So in terms of we think of tissue Hounsfield units and performing this type of calibration, so again, with ROIs shown here on the different various colors for the internal density calibration, air is usually around -1,000 Hounsfield units and is quite tight, and it's not affected by things like contrast and or scan protocol, which is really nice. Trabecular bone has a slightly higher spread, but we use this in our calibration. Cortical bone has a higher spread, and I'm going to talk about how we actually overcome this and pick the top Hounsfield units when we're doing our calibration, because it's the bottom part of that calibration curve at the air and the top for cortical bone that are the most important and going to sway how that looks. And then somewhere in the middle, we get our adipose tissue, blood, and what's missing from here is our skeletal muscle, but we get those three tissues in the middle. So going back to cortical bone and how we're actually selecting our ROIs for that. So we have two different methods of doing it. So the first one is actually to manually draw for the cortical bone. We typically like to do this in the femoral diaphysis, to draw in that nice cortical shell. However, with not CT scans, if they're done clinically, we don't always get that option if they cut them off higher, say at the femoral head. So what we've actually come up with is taking the top Hounsfield units from a skeletal site. So this is actually, I believe, L3. So these are all the Hounsfield units from a segmented L3. And we would take the top 900, subtract the top 50. So if there's any outliers, we're accounting for that. And then it's this really dark purple down here that we're using in our calibration method. So for internal calibration, it's not all peachy either. So the pros being that it is truly opportunistic. It requires no knowledge of the scan. So we can do it with various scan manufacturers or protocols. It doesn't require a reference data set either. However, there are some cons. So, or some things that can affect the internal calibration method. So the first one is image artifacts, as well as if the tissues are inhomogeneous. So if you think of an elderly individual, as they age, they typically have more fat infiltration into their skeletal muscle. So that could throw off how your calibration works. And the reconstruction kernel can also have an effect on the overall calibration. And we have our PhD student here as well, she's hiding behind the pole, Bryn Matheson, and who's working on these aspects. And the aspect I'm currently working on is CT contrast. So coming back to the calibration portion, when we are thinking about internal calibration, and what I'd like you to keep in the back of your head is the CT contrast component. So CT contrast can significantly change how the Hounsfield units interact with these various tissue. So like I mentioned, air is pretty straightforward, is not affected by contrast or CT scan protocols. Adipose and skeletal muscle, a little more questionable since they are vascularized tissues. So we do get some contrast that is infiltrating, and that also depends on the timing of when the scan is done. Blood is kind of out the door, is most affected by contrast. And then cortical bone does have some effect, but again, it's at that top portion of the calibration curve and not quite as affected. So at least with the air and cortical bone, we're not seeing these significant effects, whereas the other tissues we do. And then if I were to actually plot this, it would look something more like this. So according to the Hounsfield units, we get this grouping of the blood, skeletal muscle, and adipose tissue down here, and then cortical at the top and air at the bottom. So since we know that the Hounsfield units of different tissues behave differently after contrast administration at varying energy levels, contrast enhancement must be accounted for to obtain accurate BMD results. And so for the purposes of my study, or the one major study I've been working on, we're not including blood as one of the internal ROIs since contrast agents were injected. So just a little bit on contrast enhanced CT scans. So the use of contrast enhancement is approximately in 60% of CT scans, but anecdotally, from another one of our studies, which I'll be discussing a little later, using critical care patients, we found that approximately 90% of the CT scans had contrast enhancement. So it is pretty common. And there's an overall increase in the proportion of contrast CT scans that are coming out nowadays as well. They're pretty common. So some factors that can influence the BMD measures when we're thinking in terms of contrast. So the time from contrast administration, so whether you're in the arterial or venous phase, as well as the amount of contrast, so the dose that's actually being administered. And this can also change with the injection volume and the rate. So you can have a very quick bolus injection, or you can have a very long drawn out injection as well. So this is some of the information we've received from the radiologist, because we don't always get that information in the metadata from our CT scans. So several studies have reported how contrast-enhanced abdominal CT scans can be used for BMD assessment by applying a linear conversion formula. So still applying internal calibration, but also applying a correction factor. However, there remains some discrepancy with a different study, which is demonstrating the variability of BMD depending on the scan time and the delay since that contrast-enhanced contrast injection. So in this study, they use asynchronous calibration. And so they scan the phantom monthly prior leading up to the study, as well as monthly throughout the study. And with the BMD here, sorry, this is in Hounsfield units, we can see that in the arterial phase shown in red, we see a really sharp increase in the Hounsfield units, whereas in the portal phase or venous phase, it takes a little while longer, which makes sense. Go from arterial there. And then, so these scans are performed really quickly. So it, approximately every 2 seconds from the first 7 seconds up to 60 seconds. And then they also followed up with a 4-minute 4-phase scan as well. Oops. And sorry, this is just showing the BMD. So you get a pretty horizontal line up to about 17.5 seconds. And so this would be considered the non-contrast phase, following which we see a really steep increase during the arterial phase. So approximately from 17.5 to 41.5 following that contrast injection. So we're seeing this change in Hounsfield units also show up in the BMD. And again, this is just reiterating the sharp increase in the Hounsfield units during the arterial phase, followed by the plateau during that venous phase. So overall, this study found that higher contrast dose also yielded significantly higher BMD values in both the arterial and venous phase. And this exemplifies how both time from contrast administration and the overall dose affects BMD results while using asynchronous phantom calibration. So there is a lot of interest in the area of opportunistic CT analysis, and the main one being that we can just repurpose these routine clinical scans to perform secondary analysis of BMD. And the major benefits of doing the opportunistic CT analysis is that it allows for earlier detection of osteoporosis, and therefore you can start treatment earlier and hopefully prevent those fragility fractures. It's cost effective. You could save on not having to do a DEXA scan if we're able to get these BMD measures from scans that are already being taken for various other clinical diagnoses. It can decrease the amount of time. It could also decrease clinical resources. So again, not requiring any of those extra DEXA scans. And it's most importantly, probably decreasing radiation exposure to the patient since they've already had a CT scan. They're not going to go get more radiation from a DEXA scan, even though it is low. So however, to date, the effect of contrast enhancement on the iterative internal calibration technique I showed has not yet been examined, and that's where my study comes in. So the main goal of the contrast study is to establish the effects of contrast enhancement for opportunistically assessing BMD using the internal density calibration method that's calculating the effective energy. And a follow-up to that is to quantify the contrast error and try to figure out a correction for this. However, I'm still in the process of analyzing these scans, so the contrast correction is to be determined. Right, so this is the overall study design. So for the study, we were able to retrospectively analyze hematuria CT scans. So the nice thing with hematuria patients is that they're typically healthy and they undergo a scan protocol that includes a multi-phasic CT imaging. So the first scan would be without phase, and then they usually do an injection of contrast, and there's usually a 90-second delay, which is known as the nephrographic phase, since they're interested in looking at the kidneys. And then following which there's usually approximately a 10-minute delay, and that's to look at the urographic phase as the urine begins to build in the bladder to see what's going on for the hematuria protocol. So for our study, we had a couple parameters. So participants were identified by AHS analysts following a simple inclusion-exclusion criteria. That being that patients had to be greater than 18 years of age. We included, they had to have a hematuria CT scan. And with the study design, each participant acted as their own internal control for comparing the non-enhanced to both the nephrographic and urographic phases. So once we received the de-identified DICOMs, for the purpose of my analysis, I identified the non-contrast enhanced CT scans, following which I also identified the nephrographic and urographic phases of the hematuria protocol. And we then performed vertebral segmentation, which I'll explain a little more about momentarily. I added our internal ROIs to do our internal calibration and then got a BMD result at the end. So through this process, I have learned just how messy some of the metadata can actually be. You would think it'd be quite clean and simple. I can tell you it is not. So it speaks to some of the difficulty in implementing this approach into AHS, which is my ultimate goal. So in terms of the segmentation, we worked with a company, BoneScreen Anduin. So it's a machine learning program. And so it's not only able to identify each of the vertebra, so it's able to actually number them through, it also is able to segment them out and separate it into the various components for the vertebra. So it's hard to see, but there's actually a nice thin little cortical shell that's shown in green. We have the blue trabecular core, and then it's also able to separate out the transverse and spinous processes as well as the pedicles. So for the purposes of my study, we looked at both the trabecular core, the cortical shell, as well as combining those two to look at the lumbar body. So this is just looking at the influence of contrast on those internal reference tissues that I used for the calibration. So although blood was not used, I did include an ROI so I could see how contrast was affecting the blood. So you can see there's a very substantial increase during that nephrographic phase, as we'd expect. So approximately at that 92nd point post injection, and then begins to come back down at that approximately 10-minute delay or the urographic phase, but is still significantly higher than the non-enhanced portion. In terms of the adipose tissue and skeletal muscle, they both had increased Hans variance following the contrast enhanced injection, but to a lesser degree. And then for the cortical bone, so just only looking at the cortical shell, we actually didn't really see any change with the contrast enhancement, which is good to know, since again, it's on that upper portion of our calibration curve. However, when we look at the entirety of the L4 vertebral body, we do see a slight increase in the Hounsfield units for the vertebral body. So as a whole, this suggests that the tissues captured in the scan field of view were differentially affected by the contrast, and this is likely due to differences in vascularity. So although cortical bone and air are unaffected by contrast, and there are most important factors for the phantomless internal calibration, there remains a difference in BMD with contrast, which I will show now. So we separated them again into looking at the whole vertebral body, as well as the trabecular compartment, and then the cortical compartment. So in terms of the effects, so when we look at, sorry, my asterisks aren't showing up, but for the nephrographic phase compared to the non-enhanced phase, we have approximately a 13.1% increase. And then urographic phase compared to the non-enhanced phase, we start to see a decrease in the extent of that BMD change at approximately 3.4% higher than the non-enhanced phase. Better. Okay, looking at the trabecular bone, we see that there is more of an effect of the contrast when measuring our BMD using our internal density calibration. So with that nephrographic phase compared to the non-enhanced, we have approximately a 15.2% increase. And then the urographic phase, again, we're starting to come back down closer to our non-enhanced scans with approximately a 4.1% increase. And then if we look at our cortical bone, we actually still see some slight increase in the nephrographic phase, but the urographic phase has no significant change from the unenhanced scans. And then in terms of looking at the vertebral body, so looking at both the nephrographic and urographic, the contrast phase were strongly correlated with the non-enhanced. So we have pretty strong R-squared values if we compare both the phases to the non-enhanced. And then also looking at the bland almond plots, we don't see too much of a difference either, which is really nice. So previous research has also reported that the asynchronous BMD calibration has a strong correlation. And so now I'd like to talk about how we actually would apply this internal calibration in more of a real world setting. So one of the projects that we have ongoing in the Mansky lab is looking at critical care patients. And Ainsley Smith, the PhD student, is also here. She's taking on largely the muscle portion. Then we are together working on the bone to see how it changes after ICU stay. So the reason why we care is that patients that are admitted to the ICU, approximately 40% of them acquire something called ICU-acquired weakness. It's a pretty umbrella term. But what that means is that there's overall musculoskeletal changes. So we see a decrease in proximal limb strength and then an overall decrease in bone strength. And what this equates to for acute outcomes, this means that you usually have an increase in hospital stays as well as an increase on the time you spend on mechanical ventilation if you're already on ventilation. And then some long-term outcomes are that you typically have a decrease in physical function, a decrease quality of life, and overall increased risk of suffering a fragility fracture. So again, if we're having muscle atrophy, because these patients are typically on bed rest, they're not moving around, you're going to have muscle degeneration, as well as you can also have fat infiltration, which decreases the overall density. So if you have less muscle as well as poor quality muscle, that's something else that's not also causing mechanical load on your bones. So it's not just you standing around, it's also the muscle pulling on your bones that can help affect how bones form or resorb. So with the bone though, if you're in the ICU, you have less mechanical loading since you are on bed rest, which can result in an overall decrease in bone marrow density, or at least that's our theory. So for the study design for this critical care study, we retrospectively acquired abdominal CT scans of ICU trauma and sepsis patients. So the inclusion criteria was that they would need to have a CT scan within 48 hours of being admitted to the ICU. So that would be our baseline scan. And then they have to have a second CT scan greater than 14 days later prior to discharge. And this is specifically looking at the bone, so ignoring muscle for now. So for this, we actually segmented out the femur and then again, applying our internal calibration method, picking out those ROIs and then calibrating the scans from there to get a BMD measure. So in terms of our demographics for this study, we again had a sample size of 14 that met the criteria of having a minimum of 14 days between their baseline scan and follow-up scan. And the average time between those two scans was 25.2 days. 36% were female, 64% were sepsis patients, and then we had 36% that were trauma patients, and the median age was 52. So a little lower than what we'd see when we're looking at the whole cohort. Spoiler alert, we actually saw no differences in BMD, which was actually quite disappointing. Kind of sad to say we're disappointed we didn't see differences, but we don't really know why yet. So we were a little surprised by this. It could just be that 14 days was not enough time, but based on our sample, that was something that was attainable to look at. So some of the things we did to try to troubleshoot why we weren't seeing changes in BMD. So in terms of that cortical ROI that we would select, we actually tried a couple different things. So we tried to level match if we actually drew the manual cortical ROI at the same level. So often between the two scans, they were different lengths at the femur. So we wanted to account for that. And then when we weren't doing the manual ROIs for the cortical bone, we also tried to match the amount of femur. So when the femur was segmented as a whole, we made sure that it was actually set to the same level. So you're getting the most similar amount of volume in terms of bone between those two scans. So just overall cropping the femur. And then we also tried playing around with the Hounsfield units when we were using that function when we're taking out the top Hounsfield units. I tried it at taking the top 900 all the way down to 100 to see if that also had any change, and it did not. Okay, so I'm going to switch gears here and I'm going to talk about the implementation side, but I'd like to give a little plug first to the CIHR Health System Impact Fellowship. So this is the fellowship I'm currently on. And it's all about, like I said at the beginning, trying to take things from the bench to bedside. So with the CIHR Fellowship, it's an opportunity to develop embedded research projects and programs to address pressing problems. So in my case, I've chosen osteoporosis that face the healthcare system and help to support evidence-informed decision-making. So it's really about evidence-informed health system improvement. And then with this, it's embedding researchers into the health organization. So it's to help catalyze some of the collaborations and see what we can really come up with. So something called a learning health system in Canada. And something that is unique to Alberta is something called the Strategic Clinical Networks. So these started, I believe, approximately 2014. So they've been around for a little while. And so I'm a part of the Bone and Joint Strategic Clinical Network. And so these are focused networks on improving health aspects within each of their specific areas. So if anyone's interested, there are a number to look at. The application is coming due soon, but it has been a really nice opportunity. So in terms of implementation science in healthcare, from the very little bit I've done so far since I started in September on the Health System Impact Fellowship, it's really complicated, in short. So implementation is complex if you're trying to implement complex interventions into a complex system. So often when we come up with implementation plans, they can be quite simple and linear, but implementation itself is rarely that way. And it's normally quite a convoluted mess. So implementation is quite complicated, and adapting the implementation strategies will require adaptation. So the biggest thing is that these innovations are not being implemented into a vacuum. So we have pre-existing entrenched relationships. So that could just be how the physicians interact, what their structuring is, as well as some social structures and cultures within those contexts. So again, context also varies site to site. It can work in one site, and then a couple miles over, it may not work in another site, just adding to the complication. So when you're planning to do any implementation or adaptation, it should be iterative. You're constantly rechecking what you're doing and what's working and what's not, checking in with your partners and relationships there. It's long-term. It doesn't stop once it's implemented. It always has to be evolving, and it's multi-level. So you need to start from the ground up and get buy-in from everyone at all levels. And then in terms of actually doing some of the implementation, there's a number of different frameworks, but I'd just like to highlight the EPIS framework. And the EPIS framework stands for exploration, preparation, implementation, and sustainment. I'm not going to go through all these little factors here, but as a whole, it is an integrated process and is a determinant framework. So just briefly, it helps guide the implementation phases. And so you're constantly working between this outer context and inner context. And it's nice because you can always loop back to go back to where you were before and then try something new. So overall, it helps us support with planning, mapping, and evaluating implementation strategies. So in terms of the exploration, this is what we use to evaluate the fit of evidence-based practice. So in the case of osteoporosis, we know there's a treatment gap. So that would be considered the exploration phase. Can also be used to prepare. So identifying any key barriers or facilitators, and that helps to develop the overall plan and how you're going to put that into practice. And then in terms of the implementation, it means that you can also have the implementation and monitoring component, and then that sustainment piece. So how are we going to make sure that it's able to move forward and keep going? So using that evidence-based practice and how it's embedded into the organization, and then doing ongoing quality assurance processes. So for me, I'm currently in the exploration and preparation phase. So far, I've done a bit of clinician input, and this has been quite interesting. So I'm doing rough interviews. And so I've had some interviews with some rheumatologists, radiologists as well. And so what I really want to know from them is what are some of the barriers and facilitators that they foresee if we were to able to implement this opportunistic CT analysis to get that BMD score to identify individuals for potential osteoporosis treatment. Another main question is who takes ownership, especially with the way AHS has been restructured. This is going to get more complicated and something we have to continually grow with. So one of the things we can do is actually incorporate the BMD analysis once we get it up and going into Connect Care, since that is a province-wide system that is run in our hospitals. So these conversations often don't go as planned in the best way possible. I usually have my semi-structured interview questions, and I find my conversations usually go like this, and I'm on to going down another rabbit hole, which has been actually quite enjoyable. So for my future directions with this implementation component, I'm going to continue to interview and talk with various clinicians and start to establish what those barriers and facilitators are and try to figure out what that workflow would actually be looking like in the AHS system. One of my next steps is to actually analyze some health data. So I'm looking to put in a protocol to see if I can get some health data. And what I want to know from this is to identify who's actually being screened for osteoporosis and who's receiving CT scans. So this is just arbitrary data here I've made up. So what I'd like to know is if these individuals that are getting the DEXA screenings, first off, I believe they will probably be middle to upper class white females. So we're probably missing a whole cohort that should be getting screened. But let's just say for those DEXA screenings, if almost all those DEXA screenings are getting CT scans, that means we have too much overlap, and there's really no purpose in continuing with the CT opportunistic osteoporosis screening. However, I believe we're actually going to have a number of people here that are not getting any DEXA screenings and are getting CT scans. So there still is a purpose for moving forward with this, but we'll see what the data says. And then the next big step in terms of the science side is to actually automate the opportunistic CT pipeline. We can't have clinicians going through the whole pipeline. Currently, it's me doing it, and it's a little time consuming. So just some takeaway points for today. So going back to that research and contrast, so there's potential for a linear correction. Haven't quite figured it out yet, but I'm getting there. So we'd like to correct for the contrast enhanced CT scans and try to make them into non-enhanced CT scans so we get an accurate measure of BMD. And then just to note some of the future medical imaging, since the CT scans we're currently using are polychromatic, as the future rolls forward, we're going to see more dual energy CTs and proton counting CTs, which means we can get a better calibration in terms of figuring out what the tissue Hansfield units are. And then for the opportunistic CT, we would like to identify the at-risk populations, but also make sure that they're not getting any additional radiation. So on that point, and then in terms of the technical and implementation hurdles to overcome, trying to figure out the internal calibration and how that looks as an overall pipeline. And with that, I would like to thank my supervisors, Dr. Sarah Mansky and Dr. Stephen Boyd at the McKeg Institute, as well as Ainsley and Bryn as lab members. And then with Alberta Health Services at the Bone and Joint Strategic Clinical Network, my supervisor, Jill Robert, as well as Dr. Claire Barber. And with that, thank you.
Next presentation. Floor is now open for questions. If anyone would like to start. Yes.
Very nice presentation and a great overview of the whole method and implementation. I was wondering the BMD scores you presented at the spine. Is that one vertebra or is that the entire spine?
Which BMD scores? The T-scores, Z-scores?
The contrast enhanced CTs.
Sorry.
The one where the contrast was given and you showed BMD over the contrast time.
Sorry, what was your question then?
If there was BMD at like a certain location, like one vertebra or the entire spine?
I should know the answer to this. I don't. I believe it was at one single lumbar vertebra, but I'll have to get back to you.
Yeah, because I think it would be very interesting to see if the contrast has such a big effect and acts so fast, if there's actually like a spatial kind of like distribution.
Yes, I would assume so. I see where you're going with this.
Yeah, different bones being differently affected. At
different times. I think though, if you were to like that scan, you're never going to scan them at 2-second intervals. That's not something you would do clinically. So I don't know if that would play out in a normal scan, but I do see where you're going with that.
No, yeah, it's very interesting. Thank you.
In the plots you showed, it didn't actually look like the contrast made that big a difference. Do you think that it does, or would you say this is something that maybe we can move forward with?
So statistically, it made a difference. And then talking with Dr. Carrie, she's a rheumatologist from U of A who's quite interested in this opportunistic side. I really like her point of good enough is good enough. So from the statistical side, yes, it's significant from going from the non-enhanced to the nephrographic and urographic. But how close those actually relate to DEXAs and whether you are going to see a difference, whether someone's considered osteoporotic or not considered osteoporotic, I don't have an answer for yet. But I believe you're working on that a little bit. No, DEXA to CT, not contrast.
Venus and then Andy.
I come from a completely different world. So in your study, when you did the analysis at baseline for people who went to the hospital, and then after, on average, 14, at least 14 days. So you compared before and after, compared after and before. But did you look at people who are at risk? Because that's the aim of your study and all of it. Is did you identify people who are at risk, or because maybe medication was not possible and stuff like that, did not get some information on that? Because people average 50 years old, so some of them could be at risk of osteoporosis.
Certainly. So that was a subsample of the overall sample from the overall critical care study. If we include the muscle portion, it seemed that when we're looking at, let's just go with muscle loss for now, you lost more muscle if you were a young male. But in terms of the BMD, some of those individuals would certainly be at a higher risk of developing osteoporosis. We do have some of the clinical data in terms of who may be higher risk, but that was what we're trying to figure out from that study. I don't quite have an answer yet, though. Hopefully, I maybe answer your question.
Yeah, but so it's not total loss, like that there was no difference because of bed rest and all of that. You can identify something like in terms of the bone mineral density.
Yeah, so with the bone mineral density between baseline and the, I'll put in quotes, follow-up scan, we didn't see a difference in BMD. So part of the reason we think we maybe didn't see a difference is if someone's an older individual that's coming in, they typically would have a lower bone mineral density to begin with. And so they only have so much to lose before they're not going to lose any more. So we think that actually may be playing into why we're not seeing a change in bone mineral density upon admission to the ICU from that baseline to follow-up.
Andy and Brent or Laura? You want to put something on there to change the BMD?
Yeah, I did. I just want to carry on that line of questioning. So with the approach, what's the least significant change? And given that least significant change, could you actually measure changes in bone physiologically in 2 weeks?
Great question. I figured I was going to get asked this. We didn't calculate the least significant change, but that's one of the reasons I actually don't think we saw a difference at 2 weeks. So for this presentation, and I panicked to make sure I maybe had an answer. I was looking at some of the bed rest studies in relation to space flight. And so those are healthy adults, and they saw changes at approximately that 2-week point in actual bone mineral density. So not just taking biomarkers. But like I just mentioned from my previous answer, I think these individuals, because they are not young and healthy and they are being put on bed rest, we're not seeing those changes over the course of 2 weeks. But based on our sample, if we were to extend that out to 60 days, we would have no one. So we were trying to balance between what we were given and trying to get an answer from that to look at the bone. So other studies that also actually use biomarkers in ICU patients, and they do start to see some changes in the biomarkers. But however, as we know, biomarkers are not always an indicator of what's actually happening at the level of the bone in terms of density.
I guess I just had a higher level question about using this opportunistic approach for these osteoporotic patients. And I guess that would be like, how good or how accurate do we need to be to do something useful? Like if we just made this threshold 2.8 standard deviations below the mean, use that as our threshold for the opportunistic analysis, assuming it's more uncertainty involved, can we do something useful?
Great question. I hadn't actually considered that. So you're saying instead of making the DEXA threshold, which is 2.5, if we're using the opportunistic BMD, make it down to 2.8 standard deviations?
Presumably some lower value.
In short, I don't think we have an answer yet. I'd like to see it obviously work where we can have a set. What we would need to do, and next steps would be to do more of this internal calibration and then have that cross-validated with DEXA scans to see where they line up. What's the threshold based on this volumetric bone mineral density that we're getting from the clinical CT scans? Hopefully that answers your question.
Yeah, I guess just like follow-up, just to gain more context. When it comes to doing the phantom calibration over time type of approach, how much change in an estimate of BMD would we expect over a time course of the machine if we were doing a calibration once a month versus once a week?
You're referencing the scanner instability?
Yeah.
I don't actually know. My assumption is not too much, but that's where the internal calibration is kind of nice because we actually are accounting for that instability right within the scan since you're selecting those ROIs at the time of the scan. I'm assuming you're getting at that asynchronous may be a little bit more reliable.
Seems pretty easy to me. And it just comes
I agree with you. Unfortunately, in the clinical setting, they just do not use phantoms. So my dream is that there would be a phantom in the bed, and then every patient that ever gets a CT scan, we'd be able to calibrate their CT scan, no problem. But unfortunately, that's just not what happens.
So I was gonna ask a question related to just what you said. So why don't they use phantoms in
the clinical setting? Is it a cost thing or what's the?
I think it's a time thing. And if they do have a phantom, like this is where I'd like it in the bed because then no one has to remember to put it under the patient, but largely a time thing would be my first guess. And then also when you use phantoms in with the patient, it can cause some image artifacts because you're putting something that's very dense or something else within the scan. So it can cause some image artifacts. So maybe that's another argument, but the largest thing is time and resources.
What is the time? Like, is it
Depends on the scan.
like- okay.
Yeah, so from what I've been able to glean from discussing with some of the various clinicians is that, so I'll just give a anecdote. I'm going to take this somewhere else now, but in terms of the metadata, just how messy it is. So I thought when I first got my contrast CT scans, it was based on these timestamps we have. I thought that's when the actual CT scan actually happened. Turns out that's when the technologist would be sending it to the radiologist. And if the technologist isn't quite paying attention, they get all out of order. And then that means I have to go in and figure out which scan is which. So just to like give you some context on how messy it can be. So adding in addition to that, having to add a phantom is probably not likely to happen.
I have another question maybe regarding contrast again. Is there any studies that have done contrast enhanced CT with a QCT and looked at?
Like just regular quantitative CT?
Yeah, because if you say the cortical bone values are being kind of affected by the contrast itself, wouldn't then also the QCT pick up a higher BMD because the calibration stays the same basically, right?
So you're saying if we use QCT with phantoms and contrast?
Yeah.
So I believe there are studies that have done that where they've used typically like the one I showed, they were doing asynchronous calibration. And no, I don't think there are actually that have actually done synchronous.
Yeah, because technically if the bone itself is being affected, right?
By the contrast.
By the contrast.
Yeah.
Then you'll never be able to really calibrate it.
So
right,
from
with
what
the phantom.
we found is that the cortical is not quite as affected. So I still think we could implement some type of correction, but the trabecular bone is definitely affected.
Yeah,
So I think it depends on how you're doing that calibration.
Do you think something like a photon counting CT would make this whole process easier or harder?
I think it would help with our calibration since so because it's a polychromatic scan that we get with the current clinical CT scans, if we were to be able to use photon counting, we should actually be able to figure out the Hounsfield units of each of those tissues to get a better calibration curve. And then you'd actually know what the actual energy is as well.
Any other questions? I have one. Oh, okay. I'll go first, then we'll go Andy and then Walter.
Sure.
My one question is, how do people walk around with undiagnosed vertebral fracture?
That's a great question. I don't know. I don't know. This may not sound very nice. Maybe as you get older, you just hurt all the time.
Yeah, maybe that's what I was wondering. It's just that it's just large
No.
portion of that thing.
Yeah, I'm not sure to what degree, like, because there's various gradings on those vertebral fractures. Like if you have the highest grade, I would hope you would probably go see a doctor. But who knows?
I think they just have back pain that people think is normal and their doctors think is normal. That's like there's
So my main comment was actually kind of okay.
back pain and kyphosis and yeah.
And then
Very
for people
unfortunate.
who have these, like when they get diagnosed, is this the bone, if they go on to develop fragility fractures in the spine, or is it going to be like the hip?
It's considered one of the criteria for diagnosing osteoporosis because it is like the future considered more serious osteoporotic fracture.
I think it kind of goes like in terms of osteoporotic fractures, like by age, like you kind of get decades. So 60s, you might have a wrist fracture. If you fall, you usually extend your arm out. And as you get older, you may have a vertebral compression fracture. And then also as you get older, then you get into that hip fracture component.
Andy, and then Walter.
Sure. You just mentioned a couple of sources of uncertainty in this whole process.
Sorry, I missed that first part.
Like just throughout your presentation here, you mentioned a couple of sources of uncertainty. I guess I'm just trying to wrap my head around which ones are really important, which ones are less. So I mean, I've just jotted down a few, but there's potentially more. Like we've got this calibration piece, you're really working on a lot. Then there's the segmentation of the actual bones. You're mentioning some machine learning pipeline. There's imaging artifacts, there's effective contrast. I think you just give some some context about which one of these we need to be really, really careful of, and which ones we need to be less careful of, or are they all equally important?
I mean, selfishly, I'm going to say contrast. In terms of the actual calibration, I think contrast has maybe one of the biggest effects, since if we're talking about internal calibration, absolutely, since it's affecting the tissues we're using for the actual calibration. And then I mentioned, I believe, like kernel reconstruction can also have an effect on how on the calibration as well. And I can't remember the other ones. Arguably, I'd say contrast in the context of internal calibration would have one of the larger effects.
Walter?
Yeah, I kind of missed your definition of osteoporosis. You know, you said it's the mean plus minus one standard deviation is normal, and then when you're more than one standard deviation, what mean are you talking about? What's the mean?
So it depends on whether you're over or under 50. So I'm going to mix them up now, but I believe if you're over 50, it's a T-score. So the mean would be that of the reference population, which would be the 20 to 29-year-olds. And then if you're under the age of 50, we would use a Z-score, which would then be age, ethnicity. There's one other match.
So it's a defined population, 20 to 29.
For the when.
That's where you get the mean from.
Yeah.
That's
it's just looking at the normal distribution. And then, so if you're from that, if you're over the age of 50, if from that 20 to 29 distribution, if you are greater than 2.5 standard deviations below that mean, you're considered osteoporotic.
And
there are some issues around that as well.
Specific, like for a location, or like is your like at the hip?
So I believe it's both.
It's yeah. And here. I mean, is the mean bone mineral density always the same, or would I have to do that for each part of the body, like that?
So these are for DEXA scans. So the key sites would be at your lumbar vertebra, I believe L1 to L4, as well as at your femoral neck, so in the hip. And then we can also do total body BMD, but the main ones would be at the vertebra and the hip.
So it's specific to the location, that mean?
I believe so.
Yeah. And then these 20 to 29-year-olds, those are males and females, and they are from all over the world, or are there, or do we also have to look at racial differences, ethnic differences, or do all people have roughly the same bone mineral density in their vertebrae? Or? You're
getting at all the issues surrounding some of the DEXA portion and how we actually categorize that. So from my understanding, it's 20 to 29-year-old females, which in of itself is a bit problematic if you're comparing a male to a 20 to 29-year-old female. I'm not sure on the ethnicity of that cohort. I believe it's across a number of different ethnicities as well. And people from around the world are going to have slightly different bone mineral densities compared to other regions.
So then in different regions, people might define it the same way, but actually have the absolute values different. Yeah, I was actually surprised. I just thought, you know, if you are below, I don't know, 200 units or whatever, then you would be considered osteoporotic.
No, it's done to a mean.
I'm confused that goes with because when you say, you know, you have a mean and the plus minus one standard deviation is good, then 1/3 of the population always would be outside, and so about a sixth would be below. So kind of from the beginning, you defined that about 17% of the population would be osteoporotic, and what if all of a sudden you have a population and nobody's osteoporotic, or everybody? It seems strange to me that you don't have an absolute value for bone mineral density, but that you kind of make it up, and it might be different from location to location, might be different between the sexes. It might, so you might have 700 different definitions of a bone mineral density depending on where you look at.
I think that's where the mean helps though. So if you're taking absolute values though, then you can't compare across individuals of various sizes. That makes it more difficult to compare across various sizes. So by taking it as a standard deviation, you can then classify it that way. And then I don't know if it'd necessarily be considered 17% of the overall population, because if you keep in mind, if we're looking at 50-year-olds that are over, or anyone over the age of 50, you're still comparing them down to younger, at those 20 to 29-year-olds. So presumably when those individuals are at their peak bone mass.
So in some soft tissues, tendon, ligaments, muscles, and so sometimes you try to get the mechanical properties of tissues by vibrating them and then look at the vibration response. Do people do something like that as well? Get at bone properties by using some vibrations, giving a little impulse, and then see how the bone reacts, or does that not exist in bone tissue?
I'm not sure about vibrations in terms of actually looking at how the bone reacts. They use it quite commonly to like load the bone, vibrations to load the bone. The main ones, if you want to get how the bone reacts, would actually just be to break it. So you could do. Sorry, I put a preclinical background just to be clear when it was ethical to break bones. In a human, you wouldn't do that. You'd use finite element analysis to get a measure of what the breaking point would be. And then also there's micro indentation, which can actually take a pin press and figure out what the bone pressure be at breaking. That one I don't know so much about, but is the newest technology out there in terms of measuring.
Nobody gives you a little impulse here and measures the vibration, and then
I'm not sure.
No. Okay.
So sorry, that's really interesting though. I don't have an answer for you. Yeah, Brent, anything?
Yeah, clinicians use tuning forks to try to diagnose stress fractures. It's not super reliable. Indentation, ultrasound. There's been vibration attempts.
In terms of measuring the mechanical properties, not just for loading?
Yeah, it doesn't work.
Oh, okay.
So I saw in the muscles, the values that you showed at the beginning, they were ranging between about 20 and 60 Hounsfield units. And so that's like a factor, 2-3 times bigger, the smallest and the highest. And so how do you reconcile those type of things when you do your internal calibration?
In short, currently we don't, but I do think it is something to be explored. Like I'd mentioned, as someone that ages, they're going to have a difference in the density of their muscles. So if you have more of that fatty infiltration, that's going to change how we interpret those Hounsfield units. So presumably they would be lower. So at the moment, we don't reconcile differences in some of those tissues. The one we kind of have reconciled is the cortical bone by taking those upper Hounsfield units. We're at the very top portion of that.
One of the things you mentioned is that you would like to, identify people that might be osteoporotic and might be vulnerable to breaking a bone, and then you would interfere. So let's say you diagnose me as, oh, I'm osteoporotic. So what would you do?
If I personally, or
or would specialists,
yeah.
They discover all of a sudden, wow, you're really osteoporotic. I'm, somebody is 65 years old, and then you diagnose them. What do you actually do?
So I think that's you've hit on a key component of the implementation side. So one of my big questions is who takes ownership over that data. So let's say you've gone and you've had a clinical CT scan for something else. We run our analysis. We go, oh shoot, Dr. Herzog's osteoporotic. We don't currently have a pipeline on how they'll be handled. And so through my last conversation with Dr. Rick Walker, who is a musculoskeletal radiologist, he made a really good point that a lot of these CT scans that are being done are actually being done out of the emergency department. And you can't put the onus on the emerge doctor to do a follow-up. So from some of my other conversations, it should be the ordering physician that then follows up with the patient. So what ideally I'd like to see is that it hopefully would get referred back to your primary care physician, if you're lucky enough to have one. And they would be able to then start the process on who they need to refer you to deal with the osteoporosis to get you on the correct treatment.
Let's assume this is all in place. I mean, the ideal system. What would somebody then do to make me better?
Oh, to actually make you better? So they can put you on.
Intervention be?
So one of the examples could be like denosumab. So that could help maybe improve your bones. I believe another one would be like a lendrate. It depends. I think
that's a drug.
Those are drugs. Yeah, we would probably put you on drugs. Of some description. You do have to be careful with some of those drugs because they can cause a rebound effect if you were to go off of them. That's another issue. And also just be made aware that you're osteoporotic. You may change some of your habits and then hopefully maybe participate in some type of exercise program since that can have an effect. Osteoporosis is a appropriate exercise program.
That's what I was wondering, can you, when somebody is osteoporotic, can they actually recover the bone? Can they get better?
I don't think you're never going to regain the bone that's lost, but you can help with some of the loss. You might gain a little bit, but once you're on that trajectory, like inevitably as we age, we're going to lose bone. There's not much we can do about it. We're never going to maintain that peak bone mass that we have when we're in our 20s. But we can help to hopefully mitigate how much bone you'll actually lose to hopefully stop you from getting to that fragility fracture.
Just an administrative thing, when you do these opportunistic radiographs or DEXA scans or other things, how do you get ethics? How does that work?
in terms of,
Ethics approval for the research.
so for for example, for the contrast study that I did, we received all our scans de-identified. So we were able to get ethics that way. So we didn't have to actually get consent from the individuals because we were receiving them de-identified. But that also means that we also didn't get quite all the information that maybe could have been helpful after the fact.
So as a patient, I do not need to sign a form. You can use my results without me knowing it.
Who knows, if you had a recent CT scan, you could be in my data set. Yeah, that's the way we've done this one. Yeah, retrospectively. And then in terms of the critical care, that actually gets a little more complicated. So we were able to receive approval where we didn't have to receive consent from the patients to use their images. But there are some critical care studies which are kind of interesting. If the person is not conscious, that means you'd have to get consent from a next of kin. Those are different studies, but it does become a little more complicated.
I'm just surprised that you actually can use that without the patient officially agreeing.
I think the key component there was that they were de-identified. For the contrast is that I have no way of tracing back. And I think the risk is relatively low. Like I don't have a list of medications or disease either. So I think if you look at it as a relative risk in terms of benefit, that's also probably played into the factor of them approving our ethics protocol.
There's just some famous cases, where patients have been used, 70 years ago,
Yeah.
transplant thing,
Yeah.
and they never knew about it, and now there's all this kerfuffle about it.
Yeah, yes, certainly.
I'm surprised that that's actually possible.
Is that all the questions for Kristen? Okay, let's thank our speaker again.